تسهب لنا وتسرد لنا فيها بإذن الله. ولقدام بإذن الله حناخد كل شوية الكالكوليشن بالتفاصيل بتاعتها وكل الحاجات اللي بتهمنا، وحيكون في باب للأسئلة مفتوح الناس تاخد راحتها فيه إن شاء الله. فأنا جدا بعتذر عن التأخير، وعشان السبب ده ما حابة إنه أنا أطيل في الموضوع. دكتورة نجاة أهلا بك معانا. ليلة شرفتينا وأنستينا كتير. يا ريت بس لو سمحتي تفتحي المايك بتاعك. وبنعتذر لكي. الميكروفون عندك، عرفينا على نفسك وشاكرين لك مجهودك ده جدا جدا. جزاك الله خير في ميزان حسناتك يا رب العالمين.
السلام عليكم. أول حاجة حابة أشكركم على الاستضافة دي. سعيدة ومبسوطة طبعا إنه أنا أكون معاكم. الواحد يقدم حاجة بسيطة للناس بالذات في السودان هناك. أنا خريجة الأحفاد Family Sciences، وبعدين عملت الماستر في الأحفاد، وبعد كده برضو عملت البي اتش دي في الأحفاد. وإن بتوين مما تخرجت بعد البكالوريوس اشتغلت فترة في جامعة الملك عبد العزيز في المستشفى الجامعي كأسيستنت دايتيشن في الأول، وبعدين دايتيشن، كنت بيدياتريك دايتيشن. بعدها مشيت عملت الماستر، رجعت اشتغلت في مستشفى الحرس الوطني في جدة تقريبا زي 5-6 سنوات. وبعدين لما افتتحوا الجامعة اللي هي تحت المظلة بتاعت الحرس الوطني، اتجهت للمجال الأكاديمي مع الكلينيكال. وفي نفس الوقت كنت بعمل البي اتش دي، فخلصتها وفي نفس الوقت شغالة كنت كليكتشرر، وحاليا assistant professor في جامعة هايل. برضو certified diabetes educator و registered consultant dietitian في مجلس التخصصات الصحية في السودان. registered consultant dietitian 1. طبعا معظم الشغل كان بالذات شغل البي اتش دي وكده كان عن الدايابيتس في الشيلدرن. طبعا انا شغلي كان بيدياتريكس اكثر، لكن مع البراكتس والكفرج وكده الواحد بيغطي ادلتس كمان. مع التيتشنج بيجي كمان في اكسبيرينس اكثر. فاتمنى انه طبعا الحاجه الوحيده انه انا ما عندي اكسبيرينس في السودان، ما اشتغلت في السودان، فبحتاج انه المشاركين معانا، انا بحب السيشن دائما تكون انتراكتيف. فعايزه اعرف يعني الناس اللي هم الحضور محتاجين يعرفوا شنو او الحاجات اللي بيعرفوها حاليا، شنو اللي موجود في السودان وشنو اللي ما موجود throughout البرزنتيشن او السيشن اللي احنا بنعملها دي.
تمام.
هنبدأ. طبعا هو التيوب فيدنج يعني scientifically it's called enteral nutrition. Both enteral nutrition and parenteral nutrition are under the umbrella of the nutrition support. Our learning objectives for today are to be able to identify patients who may benefit from enteral nutrition, describing the feeding routes, enteral formulas, and administration for tube feeding, choosing the most appropriate enteral formula for a given patient, evaluating an enteral feeding for appropriateness and adequacy, propose interventions to combat various nutrition-related problems that may occur with enteral nutrition. These are the general learning objectives that I want to cover throughout the different sessions. These are not the learning objectives for today's session. This is for the whole, for all the sessions. The nutrition support is the delivery of formulated enteral or parenteral nutrients, as I said earlier, to maintain or restore the nutritional status of patients. The difference between enteral and parenteral nutrition is that in the enteral nutrition, we are going to provide the nutrients directly into the GI tract using specific types of tubes or catheters when the patient is not able to consume orally. And this can include oral supplements or meal replacements and the formulas. Parenteral nutrition, this is something that is used when we cannot use the GI tract or there is a problem in providing the nutrients through the GI tract. And the nutrients are provided intravenously directly to the blood. So why we do nutrition support, why it's important. The importance of nutrition support is coming from the idea that patients who have low nutrients intake are at risk to develop malnutrition, and the malnutrition by itself is going to increase the risk of infections and increasing the length of stay at the hospital and increasing, in addition to the increase in the cost of the treatment, and of course, increasing morbidity and mortality rate. So enteral nutrition is provided for those who cannot eat or cannot eat enough, and it should be first consideration. According to the guidelines and recommendations from the different, let's say, scientific bodies like ASPEN, the American Society for Enteral and Parenteral Nutrition, or ESPEN, the European Society for Enteral, Parenteral Nutrition and Metabolism, the different academies and societies of dietetics, even the guidelines in the critical care medicine, all of them, they say the same thing, that first we assess for the ability of the patient to have enteral nutrition. And if the patient is not able to have enteral nutrition, then we can choose parenteral nutrition. Do you know why we prefer enteral over parenteral nutrition? I hope that we can exchange ideas and answers. Can you hear me? Can you hear me? أستاذة منى؟ So the patients. The parenteral nutrition is the second choice in case that the patient is not able to take orally or take the nutrients through the GI tract. And it is used as a method to providing the nutrients through the intravenously through the blood. these are some of the benefits of enteral nutrition versus parenteral nutrition. Providing enteral nutrition will create better GI barrier function. We know that when we digest the food and when we absorb it, the small intestine will take some of the nutrients and absorb it for its function and for its structure and growth of its own cells. In addition to that, we have an immune system that is created by the different types of bacteria or the flora that lives in the GI tract. All of them will help in addition to the immune system of the GI tract itself. The nutrients provided through the gastrointestinal tract will enhance all of these activities. Also providing enteral nutrition will preserve the GI immunity. It will also attenuate or decrease the catabolic response and helps in maintaining or controlling the blood glucose levels and decreasing the rates of infection. The conditions or cases where we need to provide enteral nutrition include impaired nutrient ingestion, like in cases of neurologic disorders, facial trauma, oral or esophageal trauma, congenital anomalies, especially in infants, respiratory failure, traumatic brain injury, comatose state, cystic fibrosis, GI tract surgery like esophagotomy. And in cases where the patient is taking orally, but it's not adequate. So the amount consumed orally are not adequate at all. In situations where there is a high metabolic rate, for example, like in trauma and burns, in cancer patients, heart failure, congenital heart disease, and impaired intake after orofacial surgery or injury, cases of anorexia nervosa, failure to thrive, and cystic fibrosis. Also, we need enteral nutrition when there is impaired digestion, absorption, or metabolism. Like in cases of severe gastroparesis. And this is a condition where the stomach is not able to move the digested food efficiently to the small intestine. It takes longer time to do that. In cases of, and that's why we are not going to put the tube in the stomach, the tube will be pushed down to the small intestine. Cases like inborn error of metabolism, Crohn's disease and ulcerative colitis, where there is a high rate of infection and malabsorption, cases like short bowel syndrome with minimum resection, pancreatitis. We have conditions where the patients have severe wasting or depressed growth, like cystic fibrosis, patients with failure to thrive, cancer, sepsis, cerebral palsy, and mesenteria gravis. Now, sometimes we will not be able to use the GI.
السلام عليكم دكتورة.
ايوه.
معلش بس في الفيسبوك بيقولوا لو في طريقة بس ترفع صوتك شوية أو تستخدمي مايك.
اوكي طيب حرفة. اوكي. كده كويس؟ ممكن تسأليهم؟
أيوة أنا متابعة التعليقات، واصلي ما في مشكلة. لو في حاجة ثانية بنبهك، يعطيك العافية. تسلمي دكتورة.
Okay. Let's go since there was a problem in the audio. Okay. So as I said, we will go quickly through the reasons or conditions why people will need enteral nutrition. As I said, in cases of impaired nutrients like respiratory failure or traumatic brain injury or gastrointestinal tract surgery, especially the major surgeries, inability to consume adequate nutrition orally, like in cases of hypermetabolic states, like in cancer and burns and failure to thrive and anorexia nervosa. We have also cases with impaired digestion, absorption, and metabolism. For example, like in severe gastroparesis, in cases of Crohn's disease, ulcerative colitis, where there is a problem in absorption of the nutrients. Cases that leads to severe or conditions that leads to severe wasting or depressed growth, like cystic fibrosis, sepsis, cerebral palsy, and mesothenia gravis. Now, sometimes it's not easy to give the nutrition through the enteral route, and especially when the GI tract is not functioning. Like in cases of short bowel syndrome with major resection, when they remove a large part of the intestine. And in these cases, we have to start the patient on parenteral nutrition. We cannot use enteral nutrition because the area of nutrients absorption is becoming very small. In cases like severe acute pancreatitis, severe inflammatory bowel diseases, small bowel ischemia, where there is a decrease in the blood supply to the intestine, severe liver failure, major gastrointestinal surgeries that involves the GI tract, like the small intestine and the large intestine or the stomach. In cases of critical illnesses with poor enteral tolerance or accessibility, and this can be seen in patients with multi-organ system failure or after bone marrow transplant, or in cases of severe wasting in renal failure with dialysis, and small bowel transplantation, major surgery of transplanting the small bowel or the small intestine. Now, in these cases, patients will not be able to digest and absorb the nutrients through the gastrointestinal tract, and they will be in critical condition, and they have to be on the parenteral nutrition. So how are we going to provide the enteral nutrition? There are many axes, but to choose the right axis, we have to consider different points. Number one is the anticipated length of time of enteral feeding will be required. For how long the patient will be on enteral feeding or tube feeding? Is it a short-term tube feeding or a long-term tube feeding? Because based on the length of time, they will decide about the axis or the route of inserting the tube. The degree of risk for aspiration or tube displacement. If the patient has high risk of aspiration, which means that some of the feeding particles will move from the GI tract down to the respiratory system and can cause aspiration pneumonia, and it will put the patient at risk for other problems. Or maybe the tube will be displaced, which means the tube will move from its place. If the tube should be in the stomach, it might migrate and move up to the esophagus. And this can be seen in patients with excessive vomiting and cough. And sometimes the tube can be displaced or misplaced to the trachea, which is a very dangerous situation. So in these patients, we cannot use nasogastric tube, for example. The patient's clinical status and the adequacy of digestion and absorption. Is the stomach working or not? Which part of the GI tract is doing its function properly? Because if the stomach is not able to digest the food, it means that we cannot use the stomach. We cannot put the tube through the nose to the stomach. If there is no absorption, we cannot use the GI tract at all. The patient's anatomy after previous surgical resection or in extreme obesity. Now, this is very important point. Dietitians must read the surgery report after the surgery, especially the GI tract surgeries. You have to know which part was removed and how much was removed in order to decide about the right type of feeding and the right method of or access, the appropriate access for the tube feeding. And number 6 is whether future surgical interventions is planned. Nowadays, there are many researches and research groups. Most of them are surgeons. They are enforcing the idea of improving the nutritional status of the patient before the surgery, which is called pre-surgery nutrition. If there is a plan for a surgery or surgical intervention in the future, we have to know what is the nature of the surgery and if they are going to, if this surgery is going to increase the metabolic rate or not. Is it a minor or major surgery? Because based on that, you will put your plan of management, nutritional management or diet plan for your patient before the surgery to prepare the patient for the surgery and after the surgery. Okay, now this is a decision tree or algorithm for route selection for nutrition support. It will guide you through the steps of decision making in order to decide, can I give enteral or it's better to go to parenteral or choose parenteral nutrition. So the first question that you need to ask yourself is that, does my patient meet the needs orally from energy and other nutrients? You have to compare the intake of the patient with the requirements. So if your patient's requirement is 3,000 calories and his intake is 500 calories, definitely the patient is not meeting his needs orally, okay? So if the patient is not able to consume the foods orally or the supplements, then there are 3 parts that you can follow, 3 ways that you can follow. If the patient is meeting the needs orally, if your answer is yes, so this means no further intervention and continue to monitor your patient. Just observe and follow up your patient. Now, if the patient is not able to meet his needs orally, then you can use fortified foods and oral supplements, like adding protein powder to the fluids or to certain types of foods, using glucose polymers or using MCT oil and some of the supplements that can be consumed in a liquid form orally and cover more than 75% of the patient's needs. So if you are able to cover the needs of the patient, and give more than 75% of the patient needs from energy and other nutrients, this means that the patient doesn't need to be on tube feeding. But even if with the supplements you were not able to reach the 75%, you have to go to the enteral feeding choice. Okay, but if you are able to meet the nutrient needs, more than 75% of the nutrient needs, then you can just monitor and observe your patient and do the follow-ups. Okay. So if you choose to start the patient on enteral feeding, then you will decide about the right access or the right route of feeding. Am I going to advise the medical team to insert nasogastric tube? Maybe the stomach is not functioning, so we have to put the tube down into the small intestine, so it will be nasojejunum. Or maybe we cannot use the nose at all. We cannot use the stomach at all because there is a tumor or resection they removed great part of the stomach. The patient had gastrectomy, so we cannot use the stomach, and the tube should be inserted through the abdomen, and we have to use the gastrostomy tube. Okay? Now, the second question to ask, is my patient going to need the tube feeding for more than 3 weeks? If the patient will be on tube feeding for more than 3 weeks, it's better to put the patient on big feeding or percutaneous gastrostomy tube. So providing the feeding through the abdominal cavity to the stomach. But if the patient is not able to, if the patient is able to have the tube through the stomach, then we can use nasogastric tube. Now let's move to the third choice here. Now, if the GI tract is not functioning, the patient will be on parenteral nutrition. And there is also a way to decide about the access for the enteral nutrition. If the patient is going to be on parenteral nutrition for more than 3 weeks, then they have to use central tunnel catheter or peripheral extended dual catheter. If the patient will be on parenteral nutrition for less than 3 weeks, then they will use peripheral standard IV catheter or central standard central line. Now we will talk about the different access of enteral nutrition. Number one, or the most common one, is the nasogastric route, where the tube is inserted through the nose to the stomach. And it is used for a short-term period, like 3 to 4 weeks. And the GI tract must be functioning normally. The method of feeding and how much we are going to deliver, how are we going to deliver the feeding, we can provide the feeding through bolus feeding or intermittent or continuous infusion. We will talk later about each one of these methods. The tube is inserted at the bedside by the nurse or a physician or a registered dietitian with appropriate clinical privilege. What does that mean? It means that trained dietitians can insert the nasogastric tube. And this is something that started in the United States like 2-3 years ago, and it was included in the curriculum of the dietitians that they should be trained on how to insert the nasogastric tube. Because sometimes nurses are overwhelmed, they have high number of patients to provide care for, and dietitians can help by inserting the nasogastric tubes in those situations. And the next route is the nasojejunal or nasojejunal, which means that the tube will be inserted through the nose, passing the stomach down to the duodenum or the jejunum. And this is also used for 3 to 4 weeks. And it is used in cases of gastric motility disorders when the stomach is not able to digest the food, or severe esophageal reflux, or persistent nausea and vomiting. These are the sites for enteral access. The nasogastric placement, look at the blue color. The tube is inserted through the nose down to the stomach. So it will end up in the stomach. The nasoduodenal placement, the tube will be pushed down to the duodenum. And if the patient is not able to tolerate this kind of enteral feeding or insertion, then the tube can be pushed down to the jejunum. In the nasogastric placement technique, as I said, it can be done at the bedside in the patient's room. But the nasojejunal placement and nasojejunal placement needs a radiological confirmation. It should be under the guide of radiological assessment or guidance. The next one is the percutaneous endoscopic or which is called or known as gastrostomy or jejunostomy, where the tube is inserted through the abdominal cavity to the stomach, and this is the gastrostomy, or through the abdominal cavity to the jejunum, and this is called jejunostomy. And this can be used for longer than 3 to 4 weeks. So if we know that the condition of the patient will not allow him to go back to or her to go back to the normal oral intake for a long time, more than 3 to 4 weeks, the best choice is to insert gastrostomy tube if the stomach is functioning, or jejunostomy tube if there is a problem in the stomach. This is how they insert the gastrostomy tube or the jejunostomy tube. This is a gastrostomy tube, as you can see. This is done through a surgery, which means that they have to use anesthesia and they have to use the endoscope. So if the patient is not able to tolerate anesthesia, they cannot do the gastrostomy or jejunostomy tube. If the patient will not tolerate the insertion of the endoscope, again, it will not be the team will not be able to insert the tube. So in these cases, the gastrostomy tubes or jejunostomy tube will not be the best choice for this patient. This table compares the different types of tube feeding routes, their advantages and disadvantages. The transnasal, which includes the nasogastric and nasojejunal and jejunal tube feeding, has advantages and disadvantages. The nasogastric or the transnasal, it's the easiest to insert, and it can be confirmed easily that the tube is in the stomach by doing the aspiration and using the stethoscopes and listening to the bowel sounds. And this is the least expensive method, and the feedings can be given intermittently, like every 3 hours or 4 hours, or through an infusion pump as a continuous feeding. But it has a high risk of aspiration in compromised patients, in patients with a high risk of aspiration. Risk of tube migration, as I said at the beginning, that the tube can misplaced or moved from the stomach up to the esophagus or down to the small intestine. And if it moved to the small intestine and we are providing a formula or using a formula that needs digestion, we know that the small intestine does more absorption than digestion. So the feeding will not be completely digested. The nasoduodenal and nasojejunal, the advantages are that it has a lower risk of aspiration in compromised patients compared to the nasogastric. method of feeding. It allows for earlier tube feeding than gastric feedings during acute stress, and also after surgeries, because the small intestine will resume its functions quicker than the stomach after the surgery or after the exposure to anesthesia. The nasojejunal and nasojejunal may allow enteral feeding even when there is obstruction or fistula or medical conditions that prevent gastric feeding or feeding to the stomach. But it has some disadvantages, because one of these is that it is more difficult to insert and confirm the placement. As I say, that we need radiological guidance, doing like an ultrasound or X-ray to confirm the placement. There is a risk of tube migration to the stomach, so the tube will move from the stomach from the small intestine to the stomach. Now, to provide the feeding, we cannot use intermittent feeding because remember, the shape of the stomach is that it's a reservoir. It's like a bag, and it can take large amounts of feeding at one time. But the small intestine is like a tube, so we cannot use intermittent or bolus feeding in the small intestine. And this means that the patient will be on continuous feeding using the infusion pump. The gastrostomy and the jejunostomy allows the lower esophageal sphincter to remain closed because the tube is not passing through the esophagus to the stomach. It must be placed by a physician or a surgeon under general anesthesia, and it might require for surgically placed tubes or general anesthesia can be required for placing the tubes. There are risks of complications from the insertion procedure, risk of infection at the site of insertion. It needs lots of care from like the hygiene and all of these things. The gastrostomy feeding through the abdominal cavity to the stomach can often be given intermittently and without a bump. And there is an easier insertion procedure than the jejunostomy. The disadvantage is that there is a moderate risk of aspiration in patients who are at high risk. Feedings can withhold or stop for 12 to 24 hours before and 48 to 72 hours after the insertion procedure. So the patient will not resume the feeding immediately. They have to wait for the wound healing at the site of insertion. The jejunostomy, it has a lower risk of aspiration. The same like the nasojejunal, it allows for earlier tube feeding than gastrostomy during critical illness and also post-surgery. May allow enteral feedings even when there is obstruction, fistula, or medical conditions that prevent gastric feedings. It is most difficult insertion procedure compared to the gastrostomy, and it is most costly method, and the feedings require an infusion pump for administration, the same like in the nasojejunal method. Now, of course, to provide the tube feeding, we have to have equipments, and the main equipment is the tube itself. And most of these tubes are made of polyvinyl, silicone, or polyurethane, and the size of the tube or the outer lumen or the diameter of the tube is described using a measurement called French size. The 1 French equals 0.33 millimeter. Most of the tubes are ranging from the size of 10 up to 14. So the smaller sizes, like the smallest one is the one that you see here in the baby, in the infant. This is a nasogastric tube, and this is the smallest one. And you can see here on the left of the screen the different sizes of other tubes. An adult also can use a smaller size tube if there is a small nasal cavity. And in infants, if the nasal cavity here is very small, sometimes they insert the tube through the mouth, and they call it orogastric tube. Okay, and this is mainly in infants and even in adults if there is a problem in the nasal cavity. These are some of the equipments like the formula bags where we put the formula or using syringes. This is the bump. Different companies have different bumps and they have the sets that are compatible with those bumps. And whenever they have an advancement or a new bump type, they will come and train the dietitians and nurses about these bumps and how it can be used. Sometimes patients will go home with the bump, and in this case, we have to teach the patient, mainly the patient educator and the nurses will train the caregiver or the sitter of the patient about the pump and how to operate the pump and the schedule of feeding and everything. This is called here on the right of the screen or the left of the screen, this is called the closed system. This is preferred, why? Because the formula comes in a very big container, like 1 liter or 500 milliliter, and you just hang the container. You don't use a bag to open this will reduce the risk of contamination. And different companies have different products for tube feeding. Okay. I will stop here because the topic of formula selection is let's say a little bit complicated topic. We can talk about it next in the next session. And thank you. If you have any question, please. The floor is yours.
دكتورة نجاة، شكرا لك جزيلا. بعتذر عن المشكلة التقنية في الحساب الأساسي، فدخلت بدخال الحساب ثاني.
اوكي.
شكرا لك، معلومات ثرية، وإن شاء الله دي بداية. يعني إحنا طمعانين فيك أكثر، وربنا يجعل علما ينتفع به وينفعك به.
إن شاء الله يا رب. آمين أجمعين إن شاء الله.
بإذن الله. آمين يا رب. الناس الحضور في الفيسبوك بيشكروك جدا، المعلومات واضحة in point وسيمبل شديد.
كويس.
على قولك الفورمولا عالم كبير، يمكن من الحاجات اللي احنا بنفتقدها في السودان ما عندنا المعلومات بتاعة الفورمولا.
ايوه انا عارفه انه ما موجوده الحاجات دي، يعني الا الناس مثلا بتجيبها من برا او كده، فعشان كده خليت الحته بتاعت التايبس اوف فورمولاز دي مفصوله، لانه يعني حتى احنا في بدايه شغلنا يعني بدون البراكتس وبتتغير الفورمولاز دي وبتحصل لها ابجريدز، وفي فورمولاز بتختفي وتجي فورمولاز جديده، لكن الواحد يعرف البيزكس بس بتاعت السلكشن اوف ذا فورمولا والديفرنت available types طبعا في الماركت وكده، بالذات اذا كان المريض جاب حاجه من برا، فيكون عندنا خلفيه ولو بسيطه عن انه او حتى كيف نلقى المعلومات عن الفورمولا دي ذاتها. يعني في ديفرنت الشركات عندها الويب سايتس بتاعتها موجود فيها كل المعلومات بتاعت من البامب للسيتس اللي احنا اتكلمنا عنها قبل شويه، للتايبس اوف فورمولاز. ان شاء الله يعني ما حيكون في مشكله، يعني الناس ما تتهيب الموضوع يعني.
ان شاء الله باذن الله، ان شاء الله كلنا ثقه، ما بيعرف بيتعلم.
اكيد كلنا في الاول كده، يعني احنا كنا من حاجات كثيره كنا بنعرفها نظري، يعني ما كنا بنشتغلها يعني عملي وكده، لكن مع الوقت شويه وفي حاجات احنا كنا بنستخدمها هسه خلاص outdated، يعني بقت يعني تخفف الفورمولا ده هسه بقى ما في، بيقول لك ممنوع، انت كده هتاثر على الاوزمولاريتي بتاعت الفورمولا، you will increase the risk of contamination. فحكايه انه الفورمولا تكون هاف سترينث دي حاجه خلاص اللي هي اكثر من 15 سنه الناس وقفتها. فكل مره بيحصل changes يعني من وقت للتاني.
علم كل يوم متطور ذاته.
نعم.
قلت لك الحمد لله العلم كل يوم متطور وبمستجداته.
أكيد. يعني لو
شكرا
أي
لك.
سؤال
أيوة. طيب بالنسبة للكومبليكيشن اللي بتحصل بالذات في النازو جاستريك، يعني لما مثلا يكون في بيشن الواحد يجي يسحب يلقى هاي ريزيدوال.
ايوه.
دي من الحاجات اللي ممكن الناس تتلخبط فيها.
أيوة
إذا مثلا أنا البيشن بياخد
أيوة.
300 ملي، جيت لقيت الريزيدوال مثلا 200 ملي.
اي دي حنتكلم عنها في المره الجايه في complications.
أيوة.
سواء الجي اي complications او الميتابوليك complications، يعني التحاليل ذاتها، البلد شوجر يزيد ينقص، الميكانيكال complications كلها حنتكلم عنها، وكيف كل مشكله ممكن تتحل.
تمام.
اوكي، حنتكلم عنها بالتفصيل
ان شاء الله.
طبعا هو اذا انا عملت طبعا في جايد لاينز مختلفه، يعني في جايد لاينز تقول لك 200 مللي معناها يستوب ذا فيدنج او ريديوس ذا فيدنج. اذا سحبت 500 مللي الكتب يعني في كتب او في جايد لاينز بتقول لك 500 مللي. فاحنا حنشوف اللي هي الليتست جايد لاينز، هل هي ال 200 ولا ال 500. ونتكلم عن كيف سواء النيرسز او الدايتيشنز will solve the problem، او حتى الفيزيشن ممكن يقول شنو يعني، هل to stop the feeding ولا decrease the feeding ولا changing the formula، ولا المشكله في الستومك ولا المشكله في السمول intestine. بتعمل اسسمنت كامل طبعا.
تمام. نشوف لو في زول عنده سؤال او تعليق عايز يقوله، مفتوح لكم يا جماعة. أي زول ممكن يعمل أميوت ويشاركنا. ما شاء الله، شكل المعلومات واضحة جدا، كل الناس استوعبتها تماما ما شاء الله. دي إشادة لك.
والله شكرا، يديكم العافية.
الله يعافيكي وجزاك الله خير، اديتينا من وقتك.
الله يخليك.
واجب علينا كلنا.
لا أكيد أكيد، يعني الواحد يعني إحنا الحاجات دي هنا الناس، يعني أنا ما في بلاتفورمز مثلا، أو يعني مرات ما بنزل السودان طوال كده، فما قادرة أشارك مثلا في نشاطات أو في حاجات كده. فجزاكم الله خير، يعني فتحتوا لنا باب إنه إحنا نحاول حتى ولو نفيد بحاجة بسيطة يعني. لأنه هنا ما شاء الله طبعا عندهم هنا الأكتيفيتيز والحاجات دي كتيرة، يعني بتتعمل يعني سواء أونلاين ولا بيعملوها يعني conferences أو workshops أو كده. وأسف طبعا في حاجات كتيرة بقت أونلاين، فالناس لو عايزة يعني في حاجات كتيرة بقت ويبينارز وفري وكده. أنا عارفة في مشكلة شوية في النت في السودان وكده، لكن مرات الحاجات بتكون موجودة في الويب سايت ذاته نازلة مسجلة، يعني حتى لو سجلتي وما حضرتي بتلقيها موجودة بعد كده، يعني بيرسلوا لك إيميل إنه الريكوردينج بتاع السيشن موجود، ممكن تحضري في أي وقت.
فعلا فعلا. جزاك الله خير.
الله يخليك.
اليوم الجميل وبارك الله في علمك، وإن شاء الله حنتلاقى تاني وتاني بمشاركات أكثر ومعلومات سر أكثر بإذن الله.
إن شاء
يديك
الله.
العافية.
الله يخليك، شكرا لكم.
الله يسلمك، في أمان الله.
السلام.
سلام.